Good morning, INSHLT 2019, and I'm Dr. Hemant Pathare. I'm the Surgical Director of the Heart and Lung Transplant Program and the Division of Mechanical Circulatory Devices at the Jaslok Hospital Research Center in Mumbai. And today I have with me Dr. Sudhir Kushwah. It is my proud pleasure and privilege indeed to introduce Dr. Kushwaha to everybody. He is the Medical Director and of the Cardiac Transplant and VAD Program and the Division of Cardiovascular Sciences at the Mayo Clinic, Rochester, Minnesota. Sudhir, welcome to India.
Thank you. It's a pleasure to be here, and I appreciate the time you're taking to have this discussion about these very important topics.
Thank you very much. And I think this topic is very dear to your heart.
Yes.
It deals with VADs and mechanical circulatory support. So let's start off by asking you, why is there this sudden interest in mechanical circulatory support?
Well, actually the interest has always been there. And if you go back to the history of device therapy, the history goes back to the 1960s. It actually predates cardiac transplantation, because I think even then it was recognized that when the heart fails, when it gets to a certain point where it really can't support the circulation, something else is needed. And in those days, transplantation was still really more of a dream, because there wasn't any decent immunosuppression. And so even as early as the 60s and the 70s, the NIH initiated a program to try and develop appropriate circulation support for the failing heart. So over the years, we've seen a number of developments which we can obviously get into. But I think the interest now, particularly in a country like India, where you think resources may be limited, the interest stems from the fact that there are a handful of devices out there now which have actually become quite good compared to the previous eras, where they were either mechanically limited or limited by the complications which they cause. So we're in a different era. And what I would say is that we're in an era where we're going to see even more rapid development in the field in the next few years.
Right. So we started with the first generation NovaCore and the HeartMate XVE way back in the 80s, I would say.
Yeah.
And we progressed then to the second generation, which were axial flow devices, continuous flow with an axial pump.
Correct.
Like the HeartMate 2, for example.
Yes.
And the Jarvik 2000. And then we've now progressed to HeartMate 3 and the HVAD, which have centrifugal pumps.
Yeah.
Work on magnetic levitation. But the bugbear has always been the driveline, I think.
Yes.
But I think you yourself would now be working on the fourth generation VADs, perhaps, without having drivelines?
Correct. I mean, I think that drivelines, the presence of this line coming out of the abdomen, it's a mental leap for many patients to come to terms with that, number one. Yeah. But above and beyond that is the very real issue of infection and trying to control it, and chronic infection of the VAD, which really plagues this therapy at the moment. So one way is to have a totally implantable system with transcutaneous charging technology. Now that technology is there, it's been there for several years. It's actually getting better and better. And so even with the next generation of mechanical circulatory support, which is going to be fully internal, the ability to be tetherless from a device for up to 2 to 4 hours is actually a very realistic possibility. And as the devices get smaller, the power needs and power consumption is going to be less as well. Yes, so that makes it more realistic. So when you look at the HeartMate 2, for instance, which has become over the last couple of decades, I'd say, like a workhorse pump, generally pretty reliable, can deliver the output. But if you look at the power requirements of that device, there's just no way that transcutaneous charging through a battery pack in the abdomen is going to be able to support that device for very long. But the next generation of smaller pumps, it's a very realistic possibility. I don't think we're there yet where the patient will be able to go a whole day without being connected to something, but definitely 2 to 4 hours, I think, is on the horizon.
Would you say the driving force behind these VAD developments was consumer driven, as in heart patient driven, or was it hardcore biomedical engineering? I mean, what for?
Well, it's a combination of factors. I mean, if you take, I mean, I practice in the United States, and we're in a different era. If you tell somebody who's 72 years old, okay, you've had a good life and it's coming to an end, you've got end-stage heart failure, you're not going to survive the next year or two. If you go back a couple of decades even, people will sort of shake their head and say, okay, that's fine, I've had a good life, and they'll accept it.
That's right.
Now they say, well, 72 is young, and I want another 20 years, and I still want to go down to Florida and play golf, you know. And I think in the middle classes, which are growing in this country, are increasingly aware of what's out there. So if you take a 72-year-old here, they will say the same thing. Absolutely. I don't think there's any difference in the mentality. So I think that consumers are driving the process to the extent that in an aging population, obviously transplantation is not going to be realistic or feasible. That's right. And so what is realistic and feasible? You want something which is off the shelf, can be put in, and will extend life in a reliable and durable fashion. And that's what VADs represent. Now, parallel with consumer demand, or consumer awareness, I should say, is the fact that the biomedical engineering developments over the last few decades have been significant. And many of the issues which we thought were difficult to deal with are now being dealt with very well. And so the next generation of pumps is getting better.
So for the benefit of our audience, would you please explain what do you mean by bridge to transplant, bridge to recovery, or bridge to candidacy, and say destination therapy?
Right. So, and that's a very good question, very germane to the topic, and has been involved in the development of this whole field. So, bridge to transplantation basically means the ability to keep somebody supported up until the time they can get transplanted. And it's a concept which I suppose developed about 25 years ago when we first started using mechanical support, because the pumps really didn't last very long. I mean, the XVE, for example, 18 months maximum, and quite often as little as 10 months before you had device failure. So you wanted to put something in, keep the patient going, and then hopefully within that time frame they get a transplant. So it's a bridge to transplant. Destination therapy is exactly the 72-year-old I was talking about. I mean, nobody realistically thinks putting an organ into a 72-year-old is necessarily a good idea, particularly if there's a 25-year-old on your waiting list. You want to give them the benefit of transplant. So they get the pump, that's it. That's their therapy. They go on their way. They get however many years out of it and have an improvement in their quality of life, relatively free of heart failure symptoms. And then in between those two, bridge to transplant, destination therapy, you have bridge to recovery, where you may have a condition like an acute myocarditis, for instance, where there's a reasonable chance that that patient could actually recover their cardiac function. Right. In fact, if you look at the original papers from the early 90s, in fact, Dr. Leslie Cooper from our institution published the New England Journal paper on that, the acuteness of the presentation is correlated with the fact that most of those patients recover. Right. But there's a period of time where they literally have complete myocardial failure, and so they may need a period of support. And on top of that, there is this idea that maybe there are some patients who can recover their myocardial function. And so, hence, bridge to recovery. Bridge to candidacy is another concept. I mean, you might have a patient who is less than ideal from a psychosocial perspective for transplantation. I mean, they may have a history of drug abuse or alcohol, tobacco use, psychosocial circumstances which don't allow transplantation to be successful. And you might say to the patient, look, we can save your life now with a pump, we can put in a pump, and you may become a transplant candidate, but these are the things you have to deal with. If you don't get off alcohol and tobacco, we can't transplant you because that's going to be correlated with poor outcome. If you can't find a partner who can help with your medications and your home care and stuff like that, that's also going to compromise your survival post-transplant. Right. So you do these things and we'll make you a candidate. So that sort of broadly explains those terms.
So would you include patients with borderline renal function and borderline hepatic function, slightly worse than borderline, with a bad heart in a bridge to candidacy?
Perhaps. Now, it's true that some renal failure is heart failure driven. Right. And if you correct the circulation, the renal function improves and they may be perfectly good candidates. And we see that all the time. You can get an idea. So for instance, if you have somebody who comes in with moderate renal impairment and they have florid biventricular heart failure with volume overload, those patients could be hospitalized, put in the CCU, put in a Swan-Ganz catheter, put in a balloon pump, and you optimize them with this temporary support for as long as possible and volume offload them. And if their creatinine and renal clearance comes down to normal, then you've demonstrated that they have preserved renal function. It hasn't been chronically damaged. If, on the other hand, you have an older candidate who also has an elevated creatinine, you do all those measures and their creatinine doesn't come down, and the nephrologists tell us, look, well, you know, you look on the ultrasound, the kidney is small and shrunken, it's not going to improve, then that is probably not an optimal situation to proceed. So there are ways to try and figure it out.
Right. You know, we've had the rematch 1 trial, the rematch 2 trial, we have the momentum trial which should come out any day, and the endurance trials.
Yeah.
So, well, rematch 1 proved that definitely LVADs are better than medical management.
Yes.
For first and second year, because it was, I think, 58% versus 25.
Correct. Yeah, it was
and then 25 versus 8.
Yeah, correct. 2-year study.
That's right. And rematch 2 showed that perhaps the HeartMate 3 is better than HeartMate 2.
Yeah.
And do you know the early results of the endurance trial comparing HeartMate with HeartMate 3?
You know, I'm not familiar with the early results. I mean, are you aware?
No, that's why.
No, I mean, I think that if you look at the 2 pumps, they look very similar.
Almost similar.
Almost the same. Maybe the HeartMate 3 is a little bit bigger. But I will say this, is that the sort of, it's not really pulsatility. The company kind of sold it as pulsatility, but it's not real pulsatility, it's more of a phase shift. And the thrombotic complications with HeartMate 3, which is borne out in the momentum study, is minimal. And the reason for that is because of this phase shift provides a backwash into the pump, which prevents buildup of thrombotic material, which is the main cause of hemolytic issues in the HeartMate 2. See, the HeartMate 2 is just continuous flow all the time, no phase shift, no backwash. And the HVAD didn't have that. Now, the company has built in this, what they call this LVAD cycle. And that may, I don't know if there's any, valve. I don't know if there's enough data to demonstrate whether it's going to be as good. But the HVAD has had historically been more afterload sensitive and more issues with stroke perhaps. And momentum showed that really the stroke risk with HeartMate 3 is really pretty favorable overall. So we'll see.
The consensus would be that these trials show, yes, VADs are doing well, better and better.
Well, they're doing much better. I mean, if you take a step back and you look at survival figures, okay, overall, and you compare them with data from, say, a pharmacologic drug trial, you know, the difference is immense. I mean, we are prepared to accept a level of mortality and complications with VAD therapy, which in any other scenario would be thrown out. We accept it because it's the nature of the technology.
You know. So you think, what do you think is required to make VADs more acceptable to the practitioners or patients? You know, just like pacemakers are right now.
Right. Well, what I think is needed, we need a pump which emulates human physiology. So we've been through a few phases of development. I mean, the initial pumps like the XV and the Novacor were pulsatile.
Right.
Then it was thought that axial flow, continuous flow would be fine, and we've come to the realization that that's actually not very good because it's not physiological.
Yeah.
You get rid of pulsatility, you open yourself up to all sorts of problems, notably GI bleeding, angiodysplasias. I think you get degradation of endothelial function in the vascular beds, hence more spontaneous cerebral bleeds as well. And so basically we're going back to the pulsatility idea. And so physiologic flow, non-interference of the ventricular architecture. Okay, that's another thing, because we at the moment, to put it in crude terms, we make this great big hole in the apex, we stick this huge metal cannula in, and then we're diverting blood flow in the wrong way around, making this pump work hard to push it up into the aorta, where we could be assisting it in a more physiologic way. And then, of course, we need everything to be inside the body, so that, and then we have something which will be acceptable, reliable, and provide the appropriate level of support.
So what is your take on the percutaneous VADs such as the Impeller or the Tandem Heart, which work for a few days to a few weeks?
I think they're very useful in acute situations. I mean, in our institution, if we have somebody who comes in with profound cardiogenic shock, I think the Impeller is a good option. While we can stabilize and decide how best to manage that patient long term, particularly if they're a younger individual who comes in and say you can't contemplate transplantation or durable mechanical support acutely in those situations. Sometimes you have to wait for a bit of recovery, particularly if it's like an acute myocardial infarction. And so the Impeller has been very helpful. It's not without its problems. And I think that we certainly see a fair share of hemolysis, arrhythmias, migration, all sorts of issues like that. But for the most part, it provides, the 5-liter Impeller provides a good level of support.
That's right.
I think the 3.5-liter is not so good, and we pretty much don't use those so much anymore. And the Tandem Heart has been favored more by interventionalists when they're doing high-risk interventions, like left main stenting or something like that. We don't tend to use that so much now for acute circulatory support. I mean, in your institution, is that, do you use those devices as well?
Well, we've used 2 of them at Jasloke for left main stenting, as you rightly said. But we have a very limited, it is 3.5 liters, not 5 liters. Right. What is your take on doing a TAVI after an HVAD or an LVAD for aortic regurgitation?
For aortic regurgitation, we've done a handful. And when it works, it works well. When it doesn't work, it's problematic. I mean, we've had a couple of cases where there's been some migration, and the patients had to go back to the operating room or the combined suite, rather, I should say, to try and reposition or retrieve. But it's aortic regurgitation is a problem which besets many patients who've had a chronic implant for some time. I mean, the simple Park stitch, where you just get a stitch, actually is a solution which, if you think about it ahead of time, will save you the trauma of having to go through that. But we've done, I think in our place, we've done about 5 or 6 of them.
We're trying to do some sternal sparing techniques nowadays.
Yes.
Because many times we have patients who have 2 or 3 redo sternotomies or heavily calcified aortas, wherein we do a mini thoracotomy on the left side and plunk it on the axillary. Your take on that?
Yeah, I think it's great. I think if it's anatomically feasible and the surgeon is confident from the technical perspective, then I think it's a good way to go. And we too have done a few. I think we were in the lateral trial, which showed that, particularly with the HVAD, because of the small size and the location, it was lends itself to that. I don't think the HeartMate 3 is open to that possibility yet, but it's a good technique.
There's so much more to ask, but I think we're running out of time.
Yeah.
So it's been a pleasure.
Yep, thank you very much.
Taking you interview, Sudhir,
Yeah.
and welcome to India once again.
All right, thank
and
you.
before we finish, I must say Sudhir is a local Gwalior boy who's trained in London.
Yes.
And then now in Rochester, Minnesota. Welcome back.
Okay, thank
so
you.
much.
All right.
Thank you.
Good.